Good evening, everyone, and thank you for joining us for tonight's Woo You event. Tonight, we have Dr. Samantha Hornberger and Dr. Douglas Devries joining us, and they're going to discuss building a dry eye center of excellence with different practice modalities. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I'd like to introduce Dr. Samantha Hornberger. She graduated from Indiana University School of Optometry in 2005 and was born and raised in Indiana, and is a Hoosier. I knew I was going to mess that up. Hoosier through and through. Loving Bloomington so much that she remained there to complete residency training with a focus on cornea disease and contact lenses. Dr. Hornberger owns a private practice in Dearborn County, Indiana, that she opened cold in 2013 and recently expanded to be able to serve more of her hometown community. She is the president of the Southeastern Society of the Indiana Optometry Association, serves on the Speakers Bureau for several companies, as well as doing speaking engagements for practice management and continuing education. Dr. Hornberger's passion is sharing knowledge with and promoting her fellow eye care professionals to help them be more successful, and is grateful to also be providing high-tech but approachable eye care to her hometown community. These are financial disclosures. And then Dr. DeVries, he co-founded the Eye Care Associates of Nevada in 1992, and since that point has limited his practice to diseases of the eye and surgical co-management. His specific area of interest has been in ocular surface disease, which makes up the majority of his clinical practice. He is the director of the optometric residency program and is an associate clinical professor of optometry. Graduated with a degree in financial management from the University of Nevada and received his Doctor of Optometry degree from Pacific University. He has served as president of the Nevada Optometric Association, as well as the Great Western Council of Optometry. He lectures nationally and internationally on anterior segment eye disease, and appropriately so, is now in Alaska presenting tonight, right? And then, do you say you're presenting tonight?
Yes, yes, I am. I just am looking at the most spectacular view out this window of a frozen lake. And earlier there was a deer on the opposite shore running across. So it's pretty amazing.
That's amazing. Well, we'll all try to pretend like we're there as we're sitting in front of our computers. So here are his financial disclosures, all of which have been mitigated. And I'll let you, Dream Team, take it away from here.
Thank you. So excited to be here tonight with Woo You. I've been looking forward to this for weeks. So hello to Dr. DeVries. How are you this evening?
I'm doing well, Sam. And I got to tell you that our basketball team, our coach is now Greg Alford. And being a Hoosier, you certainly know that name very, very well.
We do. We do. Yeah. Where's he coaching now?
University of Nevada, Reno.
University of Nevada. All right. Very good. Yeah. You got a good one there.
Yes. Yes. He is good. He is good.
Yeah.
It's a pleasure to be here with you. I have, like you've been looking forward to this. I think that we have such different types of practices that we're in right now, and with my practice, which is a medical surgical referral center, and then with your practice, I think we'll just have a lot of insights to share of how to incorporate some of these in different modalities.
Yeah, I hope that people can take a lot of good tips from this, and how you approach dry eye in a big, like you said, referral center, and then how a practice like mine that is, primarily primary care and kind of full scope optometry in a hometown clinic. So we already reviewed these, so I'm just going to skip those here. I think everybody's pretty aware probably of the dry eye definition that came out of the TFOS DEWS 2, but you can't have a dry eye lecture without at least mentioning DEWS 2 and the findings that came out of that. So dry eye in that compendium, there's came up with that dry eye is a complex chronic disease involving tear film changes, ocular surface damage, inflammation. And in my mind, and I'll see if Doug, if you agree with this, but for me, dry eye really comes down to kind of two things, and it's inflammation and obstruction. Would you agree with that?
Well, yeah, 100%. Really, we see that whole vicious cycle, and it doesn't really matter where you enter the cycle. It doesn't matter whether it's a low volume. It doesn't matter whether it's high evaporation. But when you enter that cycle, it's going to end in one thing, and that's going to be tissue damage. And then that becomes, what we're all do every single day, and that's vision. And when we start affecting vision, and in my world, when we start affecting surgical outcomes, because we're into that vicious cycle. And so I think it's really widely accepted now that inflammation is a part, but before inflammation comes along, we may just have an increase in evaporation that then is going to drive that. And, to that point, I would say, let's take a look at the consummate aqueous deficient patient. That's going to be a Sjogren's patient. You ever see a Sjogren's patient with an MGD?
Never. So, one of the things that I thought about when I was thinking about this topic was how we as clinicians diagnose dry eye disease, and how maybe a clinician who has not ventured into dry eye necessarily as a specialty yet, how they can think about starting to diagnose more dry eye disease and ocular surface disease. I think these are kind of the big 5 things that most of us that are doing dry eye are doing. And that's, having some sort of questionnaire that patients fill out. In my office, that's SPEED. What are you using in your clinics?
Yeah, I use SPEED also. And I found, and I've been criticized before where people say, well, that really is biased toward MGD. Well, I'm okay because 86% of the dry eye is involved with MGD. So if it biases a direction, I'm okay with that. And I really consider questionnaires, that's the low-hanging fruit. Those are patients that are telling you that they have a problem. You're going to find others, but this is a patient that is just saying, hey, I have a problem. And I think the questionnaire takes care of a lot of guesswork, and we know before we go in the exam room. But I use the SPEED as well.
Yeah, I agree. I think SPEED is just a really accessible questionnaire. What I tell patients is, listen, this isn't used to compare you against anybody else. I'm going to use it to compare you against you so that I can see what level of symptoms you feel like you're having. And also over time, how big of an impact am I having on those symptoms as we start to treatment? I really think there's 3 things on this list that pretty much any practitioner could pick up and start doing tomorrow to diagnose more dry eye. Using a questionnaire like the OSDI or SPEED, history, just simply asking about symptoms and the timing of those symptoms, and then the slit lamp exam, looking at lids, looking at lashes, staining, doing a little diagnostic expression. Those are things that pretty much anybody could start doing right away.
And that's really the beauty of this, is that you don't need to go out and initially invest in a bunch of equipment, because we have all the equipment we need. Add a little bit of fluorescein dye into the mix, and with the slit lamp, and we really have everything with a questionnaire, with the history and the slit lamp. And I think it'll then evolve. And I think it's really one of those things. Be careful what you ask for, because once you start really looking and doing the questionnaire and staining, you're going to find that plethora of patients that really need some help and is willing to help you build that component of your practice. And that's I think is very encouraging, is you don't have to go out initially and make a bunch of investments.
No, and I always say, if you don't want to start treating dry eye, don't start looking for it, because you're going to find it everywhere once you start looking for it.
Pretty rampant, yes.
Yeah. So I kind of want to talk a little bit, like I said, we talked about the vicious cycle of dry eye disease. And for a lot of people, that does start with MGD, and starts with obstruction. And so one of the first things that I think about when I am treating a patient is, how do I attack that? How do I solve the obstruction issue? And usually that's going to be some kind of thermal expression to get those glands open and expressing again, and hopefully producing healthier oil over time. What is your favorite mode of expression in your clinics?
Well, the very favorite mode that I have is actually in the beginning of that exam is where you start by pressing on my meibomian glands and take a look, because there's this whole phenomenon called non-obvious MGD. Well, it's only non-obvious if you don't press on the meibomian glands. Once you press,
Right.
you know whether they have MGD or not. And I think that's one of the, with the questionnaire combined with doing that in the exam room. And what I'll really encourage practitioners that want to get started is take a look at their own practice demographics. Who are the patients within? Because, we talk about our patients, Sam, and, they're going to be totally different between your patients and my patients. And I think every practitioner, if they have a patient do a questionnaire and then they take the questionnaire, flip it over and press on the meibomian glands, they're going to know exactly how many patients are candidates for that. And then we're going to move toward, and really thermal expression, I do have all of it. I have automated, I have semi-automated, and I have manual expression, and I use them interchangeably depending on. But if you just have one, there's so many variations right now, and it's so inexpensive to get into thermal expression right now because of the different modalities. What do you use in your practice?
I have an iLux that I use occasionally if I have just really stubborn glands. Most of the time, I use a combination of IPL and LLT for a lot of my dry eye patients. And I find that the low level light therapy does a really good job of liquefying that mebum so that I can express. And then I use either a cotton swab or a lid stick to express after that, and find that I get really good expression really gently after I've done the LLT treatment.
Yeah, and do you have any of the intelligent manual expression where you put them on and let those lids heat up for 15 minutes? Do you use that modality at all?
I don't, but again, I use a mask-based low level light therapy system that gets those LEDs really close to the lids. So, versus direct contact, it works really well.
Yeah, and I do think that that's the beauty of it, is there are so many different methods you can go. There's a lot of ways to skin this cat when you go to actually looking at some type of expression of the meibomian glands with low level light therapy, with using IPL, which I use, and then I use some of the thermal expression procedures, and really they're very interchangeable depending on your clinic. I mean, on the using something like the semi-automatic, where you're going to hold it in your hand like the iLux, you're going to heat that up. That's going to work very well. The low-level light therapy like you do, and I'm really fascinated to hear more about that and how you're using that in your clinic. But there are, and there's a lot of different ways to do it, and we all have success. So there's not just one way you have to go into this and start looking at it. So I'll be fascinated to hear about the low-level light therapy as well.
Yeah. And, one point on the diagnostic expression that you were talking about before, I think it's really interesting. And I spend a lot of time not just looking at, how many glands are giving oil, but also what's the quality of it? Is it clear? Is it cloudy? Is it thick but expressible? Is there nothing coming out? Is it one of those where, you give a little pressure and there's a little pop and then there's oil that comes out? I kind of spend some time when I'm doing that diagnostic, again, not just looking at how many glands, but kind of what's going on with the gland itself.
Oh, I totally agree with you. I think you have to look at both the looking at the function and the structure. And the function is all about that. What does it look like? Is it clear? Is it turbid? Is it thickened? Is it paste-like? And I would also say that, at least for me, it's very satisfying when I have one of those that, like you did, where you press on it and it kind of pops, and then all of a sudden you realize that it's coming out. And you've just helped that patient. So
right. Yeah. Yeah. So then, if we're going to talk about evaporation, which is, where MGD comes in, then I think we also talk about, surface maintenance, right? The goal of expression is to improve the evaporation control. But that's not always an immediate thing, right? It often takes time to get us to where the eye is doing that on its own. So, I always have options for my patients. Um, with my patients, I always talk about, kind of three different modes of treatment, and that's the do-it-yourself treatment, the prescription treatment, and the kind of interventional treatment. So things like preservative-free artificial tears is something that, I'll recommend to pretty much every dry eye patient. It's not something that I want them using 8 times a day, hopefully, if I'm doing my job well. But it's always part of the package. And then I'm curious your take on the newer option that we have with the perfluorohexyl octane. That's a mouthful.
It is a mouthful. And, I've been looking at this for a couple of years and looking at the clinical studies and looking at, and it was very, very exciting to see this. And I find that patients are very, very excited about it as well. I'm finding that, and now I have several hundred patients on perfluorohexyl, and I explained to them that it's like putting this little dome over the cornea, that it's going to last 4 to 6 hours. It's going to prevent evaporation. And one of the things that I've noticed is you look at that cornea that has the perfluorohexyl on it, the tear is still going to break up underneath it, but think of it like a thin cornea or a thin covering over that cornea, because the fluorescein won't mix with that molecule, but it still mixes with the tear. But if the tear is breaking up the same, but you have this covering over, that's where you start getting the clinical results of the healing. So I'm really impressed by what it's doing, the comfort. And, with artificial tears, what we tend to find is most patients will be on at least 3 different types of tears that they have self-selected before they come to us. And they want to find out. So that's the first thing. I think one of the first questions I ask, they'll say, well, I've been using artificial tears. What exactly have you been using? And more times than not, they're not using some type of a quality tear. So I'll try to get them switched over to that as well.
I always find it interesting how many patients have no idea what they're using. And yet I can ask them what kind of toothpaste they use or what kind of shampoo they use, and they know exactly what it is. It makes me chuckle every time. When I say, well, what are you using? And they're, oh, I have no idea. I don't know. I got it in the drop aisle.
You look at that wall of tears in the pharmacy. Right. It's daunting.
It is.
And so I think they go in and they pick something that says same as this, and it's the cheapest one.
Yeah, absolutely. So I give every one of my patients, I have a information sheet that every patient that I am treating for dry eye, whether it's do-it-yourself treatments or prescription or interventional, front side of that sheet is what kind of artificial tear I recommend and what schedule I want them using it on, what kind of lid lash cleanser I want them using, what kind of warm compress mask I want them using, and how often, blink exercises, everything's on the front of that. And I say, okay, here's your do-it-yourself recipe, right? And then on the back, it talks about other things we can do. And I think it's really important to give very specific directions on, if you're going to use an artificial tear, this is the tear that I want you to use. And I give options. There's not just one great tear out there, but I say, take this with you to if you don't get them from me, which I do, I have them in my office. But if you're getting them somewhere else, take this with you and make sure that you're getting something that I've recommended, because there's just too much out there that's absolute junk and does more harm than good.
Sam, that actually sounds so simple, but it's so absolutely necessary, because I always think of it in this way. I can talk to the patients and they're probably going to remember about 15 to 20% of what I say. And that's why I have to have it right now. If you just trade places with that patient, you realize, hey, when a doctor is talking to you, you're trying to grab as much information, but chances are, if you get 20%, you've done a real good job. So even though it sounds simple, I think it's absolutely essential in terms of guiding a patient.
Yeah. All right. So then we have to, if we've dealt with obstruction, the ultimate end of obstruction is going to be inflammation. So we either start with inflammation or we end with inflammation. But any way we shake it, dry eye is inflammation. So we've got, our anti-inflammatory prescriptions like loteprednol. We use that for short-term treatment. And then we've got our, medications like the cyclosporin and lifitegrast for long term. But I think the key takeaway here is that really it has to be a multifaceted approach to fully address dry eye disease in a lot of people.
Well, and I agree, because I think what you want to do is you want to be able to show that patient that they're starting to get some results. And another real key element that I'll share with everybody that I do quite often is, because we're not really sure what level that inflammation is at, and that level, and they may be, one of the important points that you mentioned initially was that of the history. And the patient may have been a contact lens wearer. They may have had refractive surgery. They may have had cataract surgery. But when we take a look at how long somebody has had this possible inflammation, and maybe due to, then had refractive surgery, I think it's always wise to kind of look and test and look at corneal sensitivity, because we want patients to feel results. And a lot of the medications out now will show results within about 2 weeks. But if the patient doesn't feel it, so I always test the corneal sensitivity. And if I see that there's a slight decrease in corneal sensitivity, I'll tell that patient, you may not feel what I see. And that actually, if you tell them that up front, then they're willing to go along with the program, because patients, some of them really get impatient, for results. So, we may start to see improvement in staining. We may see improvement in tear breakup time. But if the patient is not feeling anything, they have to be helped along. And that's, again, where that questionnaire is so important. Patients do not remember what they put down the first time in terms of a speed questionnaire. So they may be improving, but they say, well, things don't really feel the same, but they'll be improving in that speed score. So I think that, absolutely, when we're attacking inflammation, we need to try to give the patient some results.
Well, so the way that I kind of approach that too is I always say that I have to prove to two people. I have to prove to myself that inflammation is part of the process that's happening. And I do that in my office with an MMP9 test, point of care testing. And then I have to prove to the patient that inflammation is part of this. So often a part of my protocol is, you have significant symptoms, you've got a positive MMP9. Okay, you're going to go on a short-term topical steroid for 2 weeks. And I'm going to see you back after 2 weeks. And that, when they feel better, that proves to them that, hey, this is part of this package. And now we can talk about, what's our long-term strategy for safely and effectively keeping this inflammation at bay. But oftentimes the first thing is just, a lot of these patients they feel like they've tried everything. In reality, maybe they've only tried artificial tears, or maybe they've tried one medication before, but didn't stick with it for long enough for it to do anything because they didn't feel the results. So when I say, listen, this is inflammation at its core, I have to prove to them that this is inflammation. If I treat that, it's going to feel better, but I can't keep you on a steroid forever. So, but it's much easier to have that conversation of, okay, here's the options that we have moving forward now that we know that treating that inflammation makes you feel better.
You said something so important, and that was, you have to prove to two people in the exam room, and that's you and the patient. And I think that's, you can look for elements like staining and say, okay, there's most likely, but I do the same thing you do. I use MMP9s. I use the inflammatory to really see if that is, because I also use that as a yardstick of how my treatment is doing also. Particularly those patients that may have a decrease in corneal sensitivity, if their inflammation is going down and they still don't feel it, at least I'm able to explain to them in a quantitative type of measure that I'm seeing this go from a bright red to a moderate to a faint to into a mild. So I totally agree with you. It's proving something to two people in the exam room.
Well, and two, a lot of times, I'm sure you run into this when you have those patients with reduced corneal sensitivity. As you start to treat that inflammation, sometimes their symptoms actually get worse, right? Because they're waking up those corneal nerves that, they're not feeling anything because their corneal nerves are dead or sick. And when you start to improve things, they actually get worse. And so you have to be able to look at them and say some quantitative way to say, no, look, it's actually getting better. We just have to keep with keep on track.
And what would you say to the docs out there that, they don't have the CLIA waiver at this point, and, in terms of what they might be looking for, that they would start an anti-inflammatory?
So oftentimes I base it a lot on speed score, because we know that inflammation is so core to dry eye disease, chances are that if you put a patient who's symptomatic for dry eye on a steroid, they're going to feel better. And so if you don't have that MMP9 test, if you don't have the CLIA waiver, which in most states is honestly pretty darn easy to get, that's a simple way to prove to both of you that inflammation is at the core of this, or at least part of it. Because if you put them on a steroid that decreases inflammation and they feel better, well, then inflammation was a part of this.
Yeah, completely agree with you. I think the speed score is important. And I also think I like to look at staining too, because when there's a high level of staining or there's some real staining that's consistent on there, again, even though you might not be able to test it in certain practices, pretty darn sure that there's going to be an inflammatory component to it.
Yeah. Yeah. I mean, it's just a pretty good bet that if you have somebody who is symptomatic for dry eye, that inflammation is playing at least some role. So then we have light-based therapies, right? So we've got the obstruction, thermal expression. We've got the pharmaceutical route that we can go to decrease inflammation. And then we have light-based therapies. So I use both of these in my practice. I use both intense pulse light and low-level light therapy. And they, I found them to do a great job of treating kind of both aspects of that dry eye. They help to heat the mebum. They help me to do a manual expression, but they're also decreasing inflammation at the same time using that photobiomodulation.
Yep, I've actually used IPL in my practice for 8 years now, and I find it such a benefit to patients, and I really find patients are very accepting of it. And the dialogue that I use with patients, if they have obstruction, if they have any telangiectasis on the lid, I'll tell them, actually, you're a candidate for a procedure that's been used for years and years in dermatology and was actually serendipitously discovered that it was helping these occluded glands. And I'll tell them that it's something called intense pulse light, IPL, been used, and they use it strictly cosmetic, and they use it cosmetic for rosacea, use it cosmetic for fine lines and wrinkles for collagen production, as well as for pigmentation. And I said, I'm going to use it 100% therapeutic, and then I'm going to manage the cosmetic side effects. And with that, the interest of patients, and they always kind of lean forward and they go, what side effects are those? Well, taking care of some fine lines, taking care of pigmentation, and taking care of the rosacea. It's about that point where the patient goes, I think I want to do that. Because we're using it therapeutically, but managing the cosmetic side effects. So when you do IPL, are you doing full face?
I do. I give people the option, but I don't charge extra for full face. So pretty much everybody opts for full face. I have a couple of gentlemen that just do the dry eye portion, but every lady that I have treated has wanted the full face and been very happy with the cosmetic results.
And my rationale for that is, if you continue to elevate and you're just going trachea to trachea, you're going to get some pretty high energy that you're doing, and you could actually create a little demarcation line where this tissue looks so good. And then, and so if I'm blending it and doing the full face, then I can use higher energy where I need it, which is right underneath the eyes and going trachea to trachea. So that's been my rationale, and patients love it. Yeah.
I started really focusing on dry eye about 3 years ago, around COVID time. And I actually, the very first kind of interventional treatment that I brought into my office was low-level light therapy. And I just added IPL at the beginning of this year, in January. Yeah. And I tell you what, I find that low-level light therapy is very good at treating MGD. Like I said, does a great job of liquefying mebum, so I can do a great expression gently with, just a cotton swab or a lid stick. But where I found that I really wanted something that I could serve patients a little bit better was those rosacea patients. And what is it? Something like 70% of rosacea patients have dry eye, something like that. And like you said, when you see those lid telangiectasias, when you see like the red rimmed lids, when you see, I mean, I can't look at a face anymore and not see rosacea on probably 75% of people that I look at. But when you see that, that little cheek redness here, you see those little telangiectasias here, and they have, even any dry eye complaints. It's kind of exciting because I know that I can do IPL on that person and they're going to get results because it just does such a great job with that rosacea related dry eye.
Yeah, I mean, it certainly does. And I'm very curious to find out, Sam, I'll tell you what I do in my practice. And when I'm seeing a new patient and I see they have obstruction and I see they're a candidate, I mention it at the very first visit that we're going to take care of the acute nature of your dry eye, but at some point we're going to have to deal with the chronic damage that has taken place and the obstruction of the meibomian gland. So right off the bat, I mention that as a treatment to the patient. I don't do it stepwise and wait. I'll mention it. And more times than not, the next time I see that patient is for their first session of IPL. Mm-hmm. That even before I would see them back on medications, I'm seeing them because I've told them we're going to have to do something about that damage that has occurred as a result of this chronic inflammation. How do you present it to patients?
Yeah, so that's where this dry eye treatment sheet that I give every patient, like I said, on the front part of that sheet's my do-it-yourself options. So I might, if I see somebody for a dry eye workup, I'll go over, here's the things on the front of the sheet that I want you to start doing right away. I maybe even go ahead and put them on that steroid for 2 weeks. But right away, I'll say, listen, this is a short-term treatment. We just want to get you feeling better as quickly as possible. But on the back of that page, I've got both information about IPL and I've got information about pharmaceutical options. And I say, I want to get you feeling better as quickly as possible, but then we need to talk about long-term options. And so on the back of this page are those long-term options that we're going to talk about. My preference here is that we treat this with IPL because it's treating the root of why that inflammation is there in the first place. You've got options for, prescription medications as well, but my patients have had really good success with treating that root cause, which a lot of people are those abnormal vessels that are bringing inflammation into the area in the first place. So I treat the inflammation, prove to them that it's inflammation, but at the same time say, here's the ways that we can long-term deal with what's causing this inflammation or the inflammation itself. And then when I talk about the difference between, let's say, IPL and, writing a prescription for cyclosporin, I say, the real difference here is over here with IPL, I'm treating the root cause, and over here, I'm just putting a Band-Aid on it. So if we do something like cyclosporin, we're probably going to, if it works, we're probably going to stay on it forever because it's keeping your symptoms and the damage under control. Whereas if we start with IPL and it works well, then it's something that we're going to do, maintenance for, but it's not something that you have to do every single day for the rest of your life.
You bring up such great points on the chronic nature of that. And I tell all my patients that it's a marathon, it's not a sprint, that it took you years to get in this. And so we're going to have to take some time to take care of some of the damage. And then we're going to try to identify some of the underlying causes. And I'll tell patients, ultimately, I will have you on the least treatment that maintains you where you need to be. And where is that? I don't know until we get there. And then that's when I start modulating treatment. That's when I'll add that treatment to take care of some of the damage, take care of some of the underlying cause. Mm-hmm. But you bring up such a great point that, hey, it's something that their physiology dictated, or, they may have had, another exacerbating factor like medications or the environment that they have. But there's only certain things we can take care of. And so this really could be this mission that we're on, and this journey we're on for extended period of time. And it just because people are so used to instant gratification that you really have to set those expectations up front. I mean, whenever I hear a patient go, I've been doing this for a year and I made progress, but it's still there, then I know I didn't do my job in really explaining that this was going to be a marathon and not a sprint.
Yeah. Well, and sometimes I have to remind myself that too, right? Because we so badly want these patients to feel better and to get them results, that sometimes we have to give ourselves a pep talk too, that, we're making progress and they're better off now than they were 6 months ago or, 9 months ago. So that's a great point.
And that's where it also helps when we have something like that speed questionnaire to find out. And one of the questions I'll ask patients also, I'll say, do you use artificial tears as much as you used to? And even though they've said, oh, I really don't notice a whole lot of difference. So, well, you know what? No, I really don't use it. And I'll say, well, we're winning then. We're winning.
Right.
You're not
Absolutely.
because that's not driving you. Your eyes aren't driving you. Because I tell the patients, your eyes are just like your teeth. The only time you notice them is when there's a problem. Other than that, we never notice our teeth.
I tell patients that all the time. Like, if you're thinking about your eyeballs, you've got symptoms. You should not have to think about your eyeballs. They should just work.
Yep.
Yeah.
Exactly.
Yeah. You brought up the speed questionnaire again too. One of my best tip for speed questionnaire, for people who haven't used it before, when I go over that with patients before they fill it out, I say, number one, don't overthink it. This first question I want you to answer is just asking you, how frequently you have this symptom. The second one's just, when you have it, how bad is it? And I say, and the symptom means whatever you think it means, right? Because, it'll give things like grittiness, irritation. And I say, it doesn't matter what I think grittiness and irritation it feels like. It's what you think that grittiness and irritation means, or what you think eye fatigue means. So I remind them of that every time they take it. There's no definition for this. It's whatever you think it means.
Yep. And I think that, as with this slide right now, when we look at this with rosacea, and you really can't look at a patient in rosacea without thinking Demodex blepharitis.
Right.
Because it just is so common. That we see that. And I think now that we have treatments for this with the 0.25% lotilaner, I don't think we're going to really fully realize exactly how much this contributed to the symptoms that patients have until they feel better. And I think that's what I'm seeing right now is patients, they'll say, it's kind of like if somebody doesn't feel good and they have malaise, they go, I didn't realize how rotten I felt until I felt better.
Right.
And I think this is one of those things as we start identifying Demodex blepharitis. Are you seeing this with a great prevalence?
I see it in so many patients every day. When you start looking at lids, you can't not see Demodex. Every patient, comprehensive exam in my chair, slit lamp, it's, I look at the surface and then, okay, look down for me. And you look at the base of those lashes. And if a quarter to 30% or more of your patients do not have Demodex, you are not looking for it, because I see it literally everywhere. And you're right, the correlation between Demodex and rosacea is huge. A lot of people think that it's very causative to the rosacea is the Demodex. So, but yeah, if you're looking for it, you can't miss it.
And I think one of the things with Demodex blepharitis is it is the easiest thing that we can possibly diagnose in our patients, because it's not, oh, I see collarettes. Do they have Demodex? If they have collarettes, they do have Demodex. It's pathognomonic for that. And I think what we do, it's something that is such a simple step in the slit lamp exam, and that's asking a patient to look down. If they look down, you will see those collarettes. And in one prevalence study, and this was all comers to eye care practices, both optometry and ophthalmology, all comers into an eye, and having those patients look down, it was 58% of those patients had collarettes. And that was just, that's young people, that is middle-aged, that is the older demographics. And when you look at that prevalence, really easiest thing there is to diagnose, have the patient look down and look for the collarettes.
Yep. I'm probably writing at least 5 to 6 prescriptions for lotilaner at this point a week. And I'm not in a super high volume. I'm not in a, that's probably 10% of my patients per week are getting a prescription at this point. And I'm starting to see those follow-ups for patients that I put on it as soon as it came out, because I was really excited when it was finally available. And I'm frankly amazed that it works the way that it does. I mean, I've seen 2 patients back now that had probably 75% lashes with collarettes. That's typically how I look at it, is, 0 to 25, 25 to 50, 50 to 75, 75 to 100% lashes with collarettes. That without any mechanical anything, no cleansers or anything, I'm seeing like a collarette on a lash. Like I've been really pleased and pretty amazed. Have you started seeing patients for follow-up?
Yeah, I did, because I had a whole list of patients that I've been making for the
Right.
past year. So the day I got
Yeah.
approved, I sent it.
Yeah.
I started seeing patients then just right away after, because they might have been scheduled for their follow-up. So they may have been
Yeah.
on it 2 weeks, they may have been on it 3 weeks. And I see in these improvements, and and I'll have doctors say, well, why should I treat this when we haven't treated it before? Well, because we now have an answer that gives efficacy, where before we didn't have a good answer. And so then you kind of waited. If you saw something that was really bad, you'd give them tea tree oil, you'd give them some type of, which you knew was going to be fairly ineffective and somewhat obnoxious to the patient. And I really see, because if there is a collarette on a lash, it doesn't mean there is a Demodex. That means that there is multiple Demodex in that to form that collarette. And so my tolerance is very short to go ahead and prescribe. And I'll tell you that the biggest thing you have to do is you have to tell the patient. If you tell a patient that they have Demodex blepharitis and Demodex is a mite, they say, I want it gone.
Yeah.
I mean, they're very decisive about that.
They're not cool with it at all.
No.
I usually follow that with, don't Google it. You don't want to know what it looks like. Don't Google it. Don't be grossed out. But yeah, we need to get rid of it.
And I think it's important to tell them, it's indigenous. It has nothing to do with hygiene. It just follows no boundaries whatsoever. It's just
nothing
a matter
you
of physiology.
It's just your skin chemistry. They just really like you. You're very lovable. And but yeah, let's get rid of them, so that we can reduce the risk of dry eye. We reduce the risk of styes and chalazion and all that fun stuff. So,
and I do think that we will realize down the road the contribution that this had, because the symptoms are indistinguishable from dry eye. When somebody has Demodex blepharitis, and I have some patients that's all they have is Demodex blepharitis, and they sound like a dry eye patient.
One of my favorite questions to ask a patient when I'm doing history is, when are your symptoms the worst? How do you feel when you wake up in the morning, right? Because I have found that patients whose symptoms are primarily caused by Demodex or other blepharitis, they will be worse in the morning. And patients who are, maybe not as much affected by that, they tend to be worse later in the day. You find that to be true?
Yeah, I do. And I think you bring up a great point. And that's it. Every dry eye patient should be asked, when are your symptoms the worst? And how do you feel when you first wake up in the morning? Because it can be Demodex. And one of the things that goes along with Demodex is an inadequate lid seal on those patients, because they set up that physiology. So, I'll go ahead and ask that every single patient. I ask that question. When do you feel? And I think that is the key, because if you can start addressing what's happening, you're really your success goes way up.
Yeah. Do you do core blackie on those patients that are worse in the morning?
I will do that, or I'll look for staining on the patient as well. And really just seems like, such a high percentage. And I'm seeing this crossover with those patients also having the proliferation of Demodex as well with the inadequate lid seal. But the time I'll do the core blackies, if I have somebody in the exam room, I'll go ahead and show them that, and they'll get a chance that the relatives can see. You see that little line of light that's coming out there when they're just gently closing their eyes? That's happening all night long, and that's generating a tremendous amount of inflammation. And your cornea compensates until it no longer does. Just like every other organ system we have, it compensates until it doesn't. But no, I'll do that, demonstrate that. But it really is such a meaningful test.
Yeah, and then treating those patients with an overnight ointment, treating them with a sleep mask or with lid seals, it can make a huge difference. I find this a lot with my sleep apnea patients that are using CPAPs, even the ones that say they haven't an excellent seal. Well, sometimes that excellent seal means that their lids are actually being pulled down out of alignment. And so it doesn't just have to be that there's this air escape that you would think would be the problem. Sometimes it's just that their seal is inadequate just because their mask is there.
Well, and let me tell you this story. I was talking to a pulmonologist. I was doing a lecture. We had some pulmonologists. I was talking to this pulmonologist. I said, you know, a really high percentage of my sleep apnea patients have an inadequate lid seal. And he looked at me and goes, yeah. I go, what do you mean? Yeah. And he goes, Doug, we videotape these patients while they're sleeping. We know they have an inadequate lid seal. I go, and this was like 12 years ago. I said, did you ever think about maybe sharing that with the eye care community?
Pass that along.
They said, and they go, really? You guys don't know that? I go, well, I see a high correlation, but we don't videotape our patients.
So. I don't make a habit of videotaping my patients while they sleep. So
100% right. I mean, sleep apnea patients, they are somebody, and then you put a CPAP on them, and it exacerbates the condition.
Because they have floppy lids to begin with, right? Because sleep apnea creates floppy lids. So now you've got this lid that doesn't want to stay in place anyway. And then you put a mask on and it pulls it down, and then there's air escape. So yeah, sleep apnea patients are, not always the most to report their symptoms, but when you delve into it, they're often very symptomatic.
Now, probably one of the most important questions you can ask a new dry eye patient is, when are your symptoms? When do you experience symptoms? How do your eyes feel when you first wake up? Because otherwise what you'll do is you'll be going off and treating something, and you may have more inflammation than you can fix with an anti-inflammatory. But if you can lower that inflammation, now you can address it, and now you have that success. So great point.
Yeah. So talking about intense pulse light again. So just, I always, when I give talks like this, I always hesitate because, you think that the things that you know that other people know, right? So whenever I kind of go back to the basics, I always pause for a second. But just, for people who maybe aren't as familiar with intense pulse light, it's non-invasive treatment that uses broad spectrum light targeted to chromophores in the skin. So it's targeted to your reds, your browns, selectively damaging those so that and the surrounding tissues unharmed. So it's gonna target your red telangiectatic blood vessels. It's going to target your brown pigment spots, and it does so without damaging the surrounding skin, and a lot of times actually improving the surrounding skin. So where can you use IPL? So it's going to be an in-office treatment. In my office, we have a dedicated dry eye treatment room. But before we had that, we just expanded in February. We moved into a building that's 3 times the size of our first clinic. There, I did it wherever I could roll the machine to. So it's certainly easy to do it in an exam room. I do it in primary care. You do it in a specialty only practice. So it's really easy to incorporate in both. We do, I tell most patients we're going to start with 4 sessions and then see how that goes. I do 2 to 4 weeks apart, generally 4 weeks, because I treat full face on most patients. I'm curious about this for you because you work in a specialty clinic. It's probably much different for you than it is for me. I tend to just fit my IPL patients into my regular schedule. Do you have specified days where you are just doing IPL treatments, or do you have like an IPL tech that does it in your practice, or what's that like?
I actually continue to administer the treatments on the patients because I'm always trying to titrate. I'm trying to get the levels of energy. I'm trying to improve the cosmetics along with helping. So no, and I just throw them throughout the schedule, but they have to be careful because if I was just doing that day where I was doing that, there'd be these big lag times because what happens is the techs do everything for me except for the treatment. So they're wiping the skin with alcohol. They're putting on the coupling gel. They're doing everything. And literally, I walk in and I spend about 4 minutes to do 2 passes. I will double check. I'll see what the energy is, and then I just roll through, and then I'm out again. And so if I was to just put it on a day, it would just take too much turnover time within the rooms. But if I can just run out there and run out of an exam room and spend 4 minutes with that IPL patient and then back to the exams, it seems to work pretty efficiently for me. And same thing, 4 treatments. I set them up initially, 4 treatments and thermal pulsation to follow. And I'm doing the full face as well and trying to get those higher energy levels as well. So same.
That's typically how I do it too. I have a technician that goes over the consents and questionnaires on the first visit. I'll pop in before they have any ultrasound gel on, and we'll talk just briefly about what their goals are cosmetically. I get a look at their skin. Am I dealing more with reds or browns or what? So I can figure out what energy levels I want to use. And then, she gets them all gelled up and eye seals and all that. I come in, do the treatment, talk the patient through it. And then I say, okay, Kim's gonna get you cleaned up. And she's gonna put you, I do combination therapy. I do IPL and LLT on pretty much all of my patients that do IPL. So I say she's going to put you under red mask for 12 minutes and then you're good to go. Make sure, if you haven't already scheduled your next one on your way out. So yeah, once you've been doing it for a while, and I haven't even been doing it that long, but you get really good at the flow that goes with it.
I agree.
Yeah. So, average cost for IPL sessions for patients is between $300 and $600 a session. 4 sessions needed for most patients. So if we want to talk about return on investment, between $1,200 and $2,400 per patient for the initial sessions, and then they're going to be in maintenance. So I think average is every 6 to 12 months, depending on the patient. Some are going to need it more frequently than 6 months, and most are going to need at least a session once a year. But like I said before, prevalence of ocular rosacea in dry eye patients is as high as 72%. So if you have patients with dry eye symptoms in your practice, you have patients with rosacea. And if you have patients with rosacea, you have patients that can be benefited with IPL.
Yeah, and that also does have an impact on the Demodex as well. When
absolutely.
Slight, but I have never had a major piece of equipment pay for itself as fast as my IPL did 8 years ago.
Yeah. I have to book 1 new patient a month for IPL to make the payment. So anything over and above that, it's just helping pay it off even quicker. So it's been a really great investment for my practice. Low level light therapy. So a little bit different. This low level light therapy is also non-invasive, but it's using low levels of light energy, LED light, to stimulate cellular function and promote healing, as well as create an endogenous heating effect. So this is really, like when I talk about photobiomodulation, low level light therapy is really what I'm talking about. It's that, bathing the tissue in that, especially red wavelength LED light, helps to decrease free radicals, decrease inflammation, increase oxygen production, heat the glands. That's where I really get a great expression. And that's why I do combination therapy. That's why, all patients in my practice that do IPL also get LLT with it. We do it in office, in our treatment room. Same thing, most patients are 4 sessions. It's where I started. I think it's a great starting point. But I really started to see the best results for my patients once I incorporated IPL along with it. Do you do radio frequency in your practice?
I do not. I've really been looking at that. Would like to get a little bit more information on the studies for that. And right now, I just haven't. I'm still looking for the studies on the radio frequency. So I don't use it right now, but I'm open to it, depending on what the studies show.
Yeah, I don't use it in my practice either. I know there's people that have seen really great heating results for MGD expression and things like that. And I know the cosmetic benefits of it are really well known, but yeah, I haven't used it in my practice either. And then, amniotic tissue, nerve growth factors, I consider those to be kind of more advanced, dry eye treatments. I'm sure you probably do both of those in your practice.
And I think you get there. I mean, as you start treating, and then you have those patients that you're not referring out that are more recalcitrant, and that's where you're going to start using biologics. You're going to use nerve growth factor. You're going to use amniotic tissue, and there certainly is a place in that. But that's really, as you agreed, as you have those more difficult patients.
Yeah. So, when I was thinking of like, where does the beginner start? For me, this is the list. If you're going to start diagnosing and treating dry eye, honestly, like you can start doing that tomorrow in your practice with these things: slit lamp, vital dyes, cotton swabs, the tip of your thumb to express glands. And then, start with just making recommendations for the right artificial tear, for counseling on environment and lifestyle and makeup, and maybe add some thermal expression. I think those are really easy ways to get started that don't cost a lot of money, and you probably have the resources already in your practice for. Intermediate, maybe we add some meibography. We didn't talk about meibography today, but it's a big part of what I do in my dry eye clinic. That, along with anterior segment imaging to show patients those telangiectasias that I see, that tell me that there's ocular rosacea there. We talked a little bit about the MMP9, and you could use osmolarity testing. Do you do osmolarity in your office?
We do. Yeah, I've used that for years and years.
Yeah. And then you start offering things like the thermal expression, or IPL, LLT, the light therapies. And then, moving on to amniotic membranes and neurostimulation and RF and micro, there's just a never-ending list of things that you can do to help these patients. So, I think, the thing to remember is that, everybody needs to be looking for dry eye. If you're looking for it, you're going to find it. And then figuring out where you are in this pathway of dry eye treatment in your practice, jumping in. And then, the last point on the road here is that the road's never done, and you're continuing to always learn and grow and implement new things in your practice to help your patients.
Yeah, and I agree. And I think that, as somebody starts out, the biggest concern is patient flow and how you integrate it into your current patient flow. And and you'll find the efficiencies in using staff really helps that, because you're just one person. You can only do so much, and the utilization of your staff really, it dovetails into the patient flow then. So it's not taking time, it's actually adding revenue, and you're providing a higher level of care to your patients. So I really do think that as you start you do have to look at what's that patient flow, how are you going to be efficient, how your tech's going to help you.
Yeah. And, it does take a little time to kind of find your flow with that. But, it's something that is extremely useful for a lot of our patients.